Hello, everybody. We're in the process of having everybody join the breakout rooms. There were a tiny technical glitch of people trying to join. So if you can give us a second, and then once we get our moderators in the room, we can start the videos. Looks like more people are joining. So I think we're ready. We have a critical mass. If we can go ahead and roll the slides. And so just to mention, these were the speakers that are going to be presenting today. These are all pre-recorded talks. We can go ahead and start playing.
Hello, I'd like to present this abstract on behalf of the co-authors. The abstract is entitled Lorentelimab, a monoclonal antibody against Siglec-8 depletes blood and tissue eosinophils in patients with allergic or inflammatory diseases. My disclosures are indicated on this slide. Lorentelimab targets Siglec-8 on eosinophils and mast cells. The drug has now been studied in 4 clinical trials, including over 150 patients. These studies include the recent ENIGMA study, which was focused on eosinophil gastritis and eosinophil duodenitis with 58 patients. Collectively, the data about the effect of this drug on blood eosinophils is shown in this slide. And one can see very dramatic decreases in blood eosinophilia that was sustained during the drug treatment and after the drug was discontinued. Focusing on the data from the ENIGMA trial, one can see the effects on the histological remission. This is defined by the levels of eosinophils being less than or equal to 4 in the stomach and less than or equal to 15 in duodenum. And one can see that over 94% of the patients achieved this strong remission at the various time points studied, going out to date 659. So in summary, Lorentelimab depleted blood eosinophils in 4 separate studies of patients with allergic or inflammatory diseases through 24 weeks. In patients with EG and ED, monthly dosing of Lorentelimab maintained complete or almost complete depletion of blood and tissue eosinophils through 94 weeks. Ongoing trials with Lorentelimab are focused on phase 3 and phase 2 studies related to EOE, EG, and EOD. Thank you for your attention.
Hypereosinophilic syndrome is a rare heterogeneous disorder characterized by an absolute eosinophilic count of greater than 1,500 cells per microliter with either tissue involvement or organ dysfunction. Eosinophilic hepatitis is a rare manifestation of hypereosinophilic syndrome that has not been well described. The clinical, radiographic, and histologic findings of 12 patients with hypereosinophilic syndrome with hepatic involvement were reviewed. 3 patterns of injury emerged. Inflammatory, evidenced by inflammatory cell infiltration, primarily eosinophils, with various forms of hepatocellular degeneration or necrosis, vasculopathic, in which the vasculature was primarily affected, and a mixed pattern in which there was inflammation of the liver parenchyma and bile ducts. This figure depicts the clinical course of one patient with an inflammatory presentation. As you can see, with the initiation of glucocorticoid therapy during times of flares, there was significant improvement in the clinical and biochemical parameters. Thank you.
Hi, I'm Dr. Mark Rothenberg, and I'm one of the chief lead authors on this study entitled Impact of Baseline Blood Eosinophil Count on Flare Reduction in Mepolizumab-Treated Patients with Hypereosinophilic Syndrome. Disclosures are indicated. This study was a subgroup analysis in previously reported data, which showed that mepolizumab compared to placebo was effective in a phase 3 trial of 12 and over patients with hypereosinophilic syndrome. In this analysis, we are examining the impact of the baseline blood eosinophil count on the outcome of the study, which is flare reduction. The data is primarily shown in this slide and basically shows that the drug versus the placebo has a dramatic effect irregardless of the blood eosinophil count. The data is shown as a bar graph on the left and as a rate ratio of the baseline blood eosinophil count as a function of the different response rates for the drug versus the placebo on the right. So in summary, these results indicate that patients with HES that are not FIP1 alpha positive are likely to benefit from mepolizumab treatment, irrespective of the baseline blood eosinophil count. Thank you.
Hello, my name is David Espinoza, and I'm a postbac at the NIH in the Human Eosinophil section. I'll be presenting my project, COVID-19 Infection and Hypereosinophilic Syndromes, a survey-based analysis. Hypereosinophilic syndromes, or HES, are a group of rare disorders defined by elevated peripheral blood eosinophils and eosinophil-related disease manifestations. Our project aimed to better understand infections and potential complications of COVID-19 in patients with HES. Participants were enrolled in 2 rounds of REDCap surveys with collection of demographics, HES disease status, medications, and COVID-19 exposure. We identified that 17 of 158 unique HES patients tested positive for SARS-CoV-2. This cohort of COVID-positive patients were comparable in demographics and HES status to the overall HES cohort. The hospitalization rate was similar to the 21% rate reported by the CDC on March 2020 for individuals who tested positive for SARS-CoV-2, but still higher than the 9% hospitalization rate reported for individuals with no underlying health condition. In summary, our data shows that there is no enhanced susceptibility or severity of COVID-19 to date in this cohort of patients with HES, and we are still looking into vaccine information.
This is a large real-world retrospective study evaluating the association between blood eosinophil levels and adverse outcomes in patients with chronic kidney disease in stage 3 or 4. Optum US electronic health records data were analyzed after adjusting for clinical and demographic characteristics, as well as other known risk factors for CKD in different disease stages stratified by different blood eosinophil ranges. Here are the results of the study. Hazard ratio in Cox regression analysis indicate that the patient with CKD in stage 3 or 4 having blood eosinophils above 300 are more likely to progress compared to those with normal eosinophil levels. Also, Kaplan-Meier curves show that patients with increasing levels of eosinophil progress faster. In conclusion, this study indicates that the risk of CKD progression and all-cause mortality was higher in patients with elevated blood eosinophil levels independent of known risk factor, suggesting that blood eosinophils may be used as biomarker of CKD progression.
This is a study on the real-world investigation of eosinophilic-associated disease overlap, REVEAL. The REVEAL study aimed to describe and characterize disease overlap in terms of patient demographics, disease severity, eosinophil levels, healthcare resource utilization, and costs. We used data from Optum claims between 2014 and 2019. Eligible patients had at least 2 years of continuous health plan enrollment and at least 1 out of 11 eosinophilic disease diagnoses of interest. Higher eosinophilic disease overlap rates were observed in patients with severe disease compared to those with mild to moderate manifestations of the disease. Figure 1 shows an example on eosinophilic esophagitis and eosinophilic granulomatosis with polyangiitis. We also found that patients with overlapping conditions had increased healthcare resource utilization compared with patients without overlapping diseases, as shown in Figure 2. Higher rates of eosinophilic disease overlap were associated with older age, higher eosinophil levels, and higher costs, results not shown. In conclusion, this study informs on the need for healthcare providers to query for overlapping eosinophilic diseases when assessing patients.
The majority of patients with lymphocytic variant hypereosinophilic syndrome present with continuous and soft tissue manifestation, while cardiac complications are extremely uncommon. We recently observed severe vascular complications to patients that we have been following for more than 10 years and whose clinical presentation were very benign until then. Patient 1 was a 52 years old female who experienced a stroke with right facio-brachial paresis and non-fluent aphasia. This was due to spontaneous dissection of the left middle cerebral artery. Patient 2 was a 62 years old female who developed an acute myocardial infarction due to dissection of the proximal ascending aorta and development of large pseudoaneurysm that contained neurothrombin and compressed the left coronary artery. Neither patient had cardiovascular risk factors, and both patients had persistent hypereosinophilia over the years preceding the acute event. Development of vascular aneurysms in the setting of otherwise relatively stable and benign HES has been reported in 3 other patients. Although this is a very uncommon disease, complications and its consequences are very serious.
Hello.
And I believe that is all. So at this point, just in the interest of time, I don't see a lot of questions posted in the chat, but feel free to come off mute and ask your questions directly. There's a lot of interesting talk, and you can also raise your hand as Bhavini has done. So I will go ahead and let you unmute yourself and share your video if you'd like and ask a question. Unless that was a mistake. Okay, Dr. Rufos, go ahead.
Thank you. I was just wondering why, what's the reason that lerontinemab is mostly being assessed in gastrointestinal disease? Is there some kind of rationale behind that approach, or what are the plans in terms of development?
So I believe this question is for Dr. Rothenberg, or
Yeah, this is a good question, and it's more of a business decision by the company, so I'll let Dr. Singh respond.
so Dr. Bhupinder Singh appears to be on the line too. I don't know if you'd like to take that question, or we can move on. Okay, I believe we don't have an answer for that question, so I'm going to move on to Dr. Amy Cleon. If you'd like to unmute yourself, share your video if you'd like, and ask a question.
I'm unmuted, but I'm not sharing my video because I'm driving. But I have a question for the person who spoke about the renal disease. Do you know what impact treatment has on that? So if you treat the eosinophilia and you lower it, does that improve the prognosis in chronic kidney disease?
Hi, Ami. We didn't look at the impact of the treatment on any treatment of any of the CKD stages, because this was based on the data claims analysis. So this was not really possible to perform this type of analysis.
Thank you very much. Are you aware of anyone actually looking at that moving forward?
Not as far as I know. I think this is a good idea for any more controlled trials, prospective study to look if there's any impact on treatment, on the risk of progression, and in relation to eosinophils levels in those patients.
Yeah, I mean, it's a problem with the clinical trials because many of them exclude people that have creatinine clearance below a certain amount. So obviously it would be interesting to look perhaps in a cohort of patients that are not being treated in a clinical trial, or that's being treated specifically for this reason.
Yes, we were thinking about this as well, but it's difficult to find a database, and the patient who were on biologic or treated with steroids, for instance, if there's any impact. Yeah, it's a good idea to look at.
Yeah, I mean, I think it's interesting. The counts themselves are not terribly high. They're just different in terms of the baseline count.
But look, we look at the blood eosinophils level. So as I see the other people presenting here, like TBC, and I think there is the eosinophilic driven inflammation in the many chronic diseases such as CKD.
that's true. If there are any other questions on the CKD study, feel free to put them in the chat. In the meantime, there was a question for the COVID HES study. This is for David Espinoza. Does the assessment of COVID infection rates in HES suggest that eosinophils are not playing an essential role in respiratory viral infections?
That's a good question. I don't think it says that they're not playing an essential role, but there's a lot of other confounding factors that we have to take into account. So I don't think we can say for certain that they're not playing any role in respiratory viral infections.
Right. And I think, at least for the HES patients that are included in that cohort, they have a variety of manifestations, not just, respiratory. So I think all it really tells us is that there's not, a big role for either reduction of the eosinophils or the disease itself in making more, COVID severity in these patients. Dr. Rufus has one more question.
Yes, hello. This is a question for the eosinophilic disease overlap abstract. The slides went very rapidly. 1 minute is really hard just to capture all the information that's out there. So I was wondering perhaps if you could explain more how you looked at this. What exactly did you enter in terms of search terms? What were the actual overlaps that you were interested in looking at?
Yes, can you hear me?
Yep.
So we looked at the overlap of 11 eosinophilic diseases: COPD, asthma, atopic dermatitis, bullous pemphigoid, non-cystic fibrosis, bronchiectasis, eosinophilic gastritis, gastroenteritis, EGPA, eosinophilic granulomatosis with polyangiitis, eosinophilic esophagitis, COPD, and chronic spontaneous urticaria. So we used the Optum claims to look at this, and we aimed to characterize disease overlap, so to see which diseases co-occur in which kind of clusters, in which kind of sequences, whether certain clusters are associated with higher disease severity, if patients with several comorbid diseases have higher eosinophil levels, for instance, and then also characterizing those disease clusters in terms of healthcare resource utilization and costs.
Mm-hmm.
So I think the implications are to encourage healthcare practitioners perhaps to look at those disorders not as standalone conditions, but as disease clusters, and to understand also the role of eosinophilic immune dysfunction in driving the development of several related conditions, and to try to...
And are there any perspectives in terms of looking at genomics and seeing if patients who have multiple eosinophilic conditions actually somehow have a predisposition to develop type 2 or eosinophilic diseases? Are there any?
That's an interesting question. We haven't considered that. I think it's a little bit too fundamental research question for me. I would have to check with my team. I'm an epidemiologist, but yeah, it would be interesting maybe to take it forward.
Florence, this is Danuta. I'm also involved in this study. I think this would be, it's very interesting, a really research topic, but this would require the blood for those patients who have with multiple conditions. So then we can really see, we can have some, collaboration on this. But I think it's very, right now with this database, I don't think it will be possible.
Okay, thank you.
I think we have another question from Dr. Amy Cleon.
Yeah, so one of the 3-minute talks was on the FIP1L1 PDGFRA and watershed infarct. Is that in this session?
It should be. It should be.
Should be. We hope that they join.
All right. Well,
yeah, cool. Yes, I am here.
Thank you.
Okay.
Yes.
Good. So I had a question. So do you know, oftentimes what happens is a patient has FIP1L1 PDGFRA, and because it's treatable with imatinib, the evaluation stops there. But do you know if NGS or whole genome or something was done on those patients, and whether there are other genetic factors that might predispose to watershed infarct in those patients?
Thank you for the question. So these NGS explorations are not performed routinely. so it wasn't done for these patients. But what we can say is that these watershed infarcts are shared with many eosinophilic syndromes that are clonal, but also secondary. So we're not sure, we might find something, but I can't answer because we haven't performed it.
Thanks. I mean, the reason I ask is so when you do, we've found that some of the patients, not all of them, when there's been a very extensive coagulation workup done in our patients who have these kinds of strokes with normal cardiac normal cardiac studies, that it seems, but I can't tell you that it's statistically anything. It seems that abnormalities in the coagulation pathway may be more prevalent. And so it may be that the combination of very high levels of activated eosinophils plus something else leads to infarct. And so I think it's an interesting, you have a very interesting group. There probably is DNA and RNA stored on these patients because the diagnosis of 1L and PDGFRA was made. So it might be a very similar otherwise cohort to look at to try to see if this can be dissected out.
Yes, indeed. I will report to my to my team to see if we could go further into details on the DNA samples. Thank you for your suggestion.
Thank you. And before we go to your question, Dr. Rufus, I'm going to ask a question of you in your group. Can you maybe think about or explain perhaps your thoughts on the cause for vascular dissection in the patients with LHES?
So to be perfectly honest, we're looking into it and we don't know. Obviously, the first thing that we wanted to look into was to see if there was a presence of eosinophils, as has been described in one of the 3 cases that have been published so far, around or in the vascular wall. And we actually sent some material because the second patient had a major cardiac surgery with valve replacement of the proximal aorta, coronary implantation. So all that tissue was available, and we sent it to Chris Leiferman in the States to look for granule proteins. And the problem is they had no control tissue for that. And so although they did seem to see some staining, they're not ready to really formally say that this was perhaps due to the presence of eosinophils. What was surprising in both cases is that these were patients who had very, very, very mild disease manifestations. One was not even treated because she actually had no disease manifestations for the previous 10 years. And so we can only hypothesize that this has to do with eosinophils, and it has been described rarely in exactly the same setting.
Thank you. And you can go ahead and ask your question now.
Thank you. Well, it was also a question for Juliette Tenenbaum on their cohort of patients. I was wondering if, so these were clearly patients, the majority of which the stroke was the actual inaugural symptom of their disease, if I understand. And I was just wondering if there were any differences in eosinophil counts at diagnosis in this subset compared to the subset of patients who did not have stroke.
Thank you for the question. So there was no significant difference between eosinophil blood count at diagnosis, but we have a tendency. Patients with stroke had a 12.8 giga per liter of eosinophils, whereas patients without stroke had 8 giga per liter. So it was not significant, but maybe there's a tendency for higher eosinophil blood count. However, we couldn't conclude that. And regarding other blood laboratory findings, there was no difference between the 2 groups.
Thank you. I was asking that question because it's kind of related to our short abstract.
Yes.
We saw a very, very sudden and marked increase in eosinophil counts at the time our patients developed these vascular complications. And it intrigued, it's only 2 cases, but it was intriguing to us.
Yes, indeed. Thank you for your question.
Okay, I think we have just 1 more minute for any last burning questions. Otherwise, I think we may just, have a little chat. I think one of the things that we miss about the International Eosinophil Society in person is that we actually meet all of our collaborators and make lots of contacts. So if anybody would like to just say hello and show their video, that would be great. If not, I'll just stay here and you can just look at me. I think
Which is nice.
Thanks, Florence. Yeah. Hi, Mark. How are you? It's nice to see you. These were all really nice talks, and hopefully we'll all get to reconvene back in person fairly soon, hopefully.
So Penise, do you know if the others, so some of us feel torn between the basic science and eosinophil biology and clinical work. Are these sessions recorded, and are we going to be able to watch them at a later date?
Well, I think
they are
so.
recorded.
It does recording. Yeah.
Yeah, they're recorded.
You might be able to see the other sessions too.
Yeah. But as I'm going to announce just afterwards, we're really going to be asking for feedback from the attendees on improvements that should be made based on frustrations like the one that you just voiced.
Florence, my frustration was 1 minute presentation.
like everyone. So
but
maybe
it was excellent. Thank you very much.
Denise, if we just leave the room, will we all go back to the main place, do you think? Do we dare to push on that little button?
I think you can choose breakout room and go somewhere else actually. If you hit the breakout room button, you can actually go somewhere else. So
the breakout room button.
I think at some point somebody will close all the rooms and we'll all end up back in the main room. So, so thank you very much, everybody. This was really fun. And thanks for answering all the questions to the presenters, and see you all back on the other side.
Thank you, Penise.
Thank you very much.